Thanks, Kate. Yeah, hi. So I'm Tom Crocker from the Academic Unit for Aging and Stroke Research at University of Leeds. I've been coordinating a team. Hang on a second, let me just share some slides. So coordinating the UK Multiple Long-Term Conditions Trials Collaborative team. And this is the first in our series of seminars where we're going to be talking about using individual participant data meta-analysis for multiple long-term conditions. So my involvement, I've got a background in done a number of evidence syntheses, and along with Andy, we have been developing a repository of individual participant data. And as I say, I've been coordinating this team. Peter, do you want to just briefly introduce yourself?
Yes, thank you, Tom. My name is Peter Hanlon. So I'm a GP in Central Scotland and a clinical senior research fellow at Glasgow University. Um, I've been involved in working with IPD for some time, looking at multiple long-term conditions and also at frailty. And yeah, pleased to be part of this group that Tom's been ably coordinating. So yeah, I'm going to speak a bit later on about some of our more recent work in the context of type 2 diabetes and how we've been using IPD to try and gain additional insights into MLTC within that condition.
Thanks, Peter. I think Andy's going to hang around in the background and then join us again for questions. If you do have any questions, if you want to put them in the chat, then we can monitor them there and come to them at the end. Okay, so just a broad outline. I'm going to give you a sort of why and what of IPDMA, that's individual participant data meta-analysis, talk about multiple long-term conditions and our team, and then I'll hand over to Peter, who'll give an example of applying IPDMA in diabetes and some talk about some of the opportunities and challenges in this area, and give us a specific example of some work he's done. So there's a broad challenge, we think, that individual clinical trials rarely analyse and report results from a multiple long-term conditions perspective. So despite there being a growing focus in this area, there's not a great deal of evidence, but we believe that individual participant data meta-analysis has the potential to transform the evidence base for people with multiple long-term conditions. So, as we know, guidelines and treatment decisions are often based on trials or more often systematic reviews to identify all the relevant trials and pull the results together. But individual trials are often underpowered. This means they can't provide conclusive evidence on their own. And anyway, they're conducted in a particular setting, and so there's always a question about generalizability. So we tend to conduct systematic reviews and meta-analyses, and here's an example of a meta-analysis with 6 trials contributing. But the results that are included are based on the results for the whole study population on average. What was the average effect in people who were treated one way versus the other? So these aggregate data meta-analyses are based usually on the published results, and we usually only have information about the population as a whole. So therefore, while we might know that one study has a higher mean age or more participants with multiple long-term conditions, it's very rare for individual trials to report data on whether a characteristic is associated with a difference in treatment effect. And if it was reported, you might be concerned that it was only being reported because it was interesting, but perhaps it was a result of chance. So these characteristics of the population get mixed together with all of the other things that might modify a treatment effect, such as differences in the setting, the intervention, or other population characteristics. And any analyses, subgroup analyses or meta-regression to explore these differences are subject to confounding and can suffer from ecological bias. So yeah, these so aggregate data meta-analyses also can suffer from differences in the original analyses. The outcome measures may have been treated differently. Some of them might have been dichotomized or scored differently in different trials. There may have been a lack of adjustment in some analyses, or you might be concerned that analyses have been over-adjusted in another trial. And the authors may have inappropriately excluded participants, perhaps because they discontinued the intervention. There's also a risk of publication and reporting bias because either the whole trial hasn't been reported or relevant outcomes may have been collected but not analysed or not reported. And this is likely to be because the findings were considered not interesting. In other words, they weren't statistically significant. So with these traditional meta-analyses, you're largely reliant on what's been put in the public domain. So what can we do differently? Well, individual participant data meta-analysis, or IPDMA, it involves us collecting the individual level data from original trials. So imagine a row in a spreadsheet for each participant. Preparing it so that the data from each trial can be analysed together, validating that we've got the full data set, that we can replicate the results of the original trial, and then analysing the data. And broadly, this can be done either in one big model, or you analyse each trial individually, but in a more consistent manner than might have been done previously, and conduct a traditional meta-analysis. So it's worth saying at this point that IPDMA is very resource intensive. It often takes a lot of work just to gain the agreement of trialists to share their data, although there is increasing pressure for openness. And then handling the data to harmonise it in preparation for analysis takes a lot of time and resource. And the process and analysis is also methodologically challenging, so it does require expert input. And realistically, IPDMA can only be done as a funded project, not in a clinician's spare time in the way that some systematic reviews have been done previously. However, so one of the benefits of IPDMA is that it increases statistical power, because you have control of the analysis of each trial's data. You've got a more consistent and perhaps more appropriate analysis to feed in. And crucially, it enables investigation, proper investigation of how treatment outcomes vary with different characteristics, either because people respond differently to the treatment, or because their characteristics mean their expected trajectory would be different. So we think this could be a crucial tool in enhancing personalised or precision medicine with tailored predictions. So multiple long-term conditions, talk about those now. MLTC, also known as multimorbidity. Multiple long-term conditions is now the preferred term, certainly within NIHR. And it's the presence of two or more conditions, and it's pretty common. So estimates vary, but a couple of large studies for England estimate roughly 15% of the whole population, or a third of adults, have MLTC. And actually, that estimate of a third of adults was for what they defined as complex multimorbidity. They had a much higher estimate for straightforward multimorbidity. Obviously, it depends a bit on how exactly conditions are defined and the data source. So, of course, long-term conditions tend to accumulate with age. So less than 1% of children have MLTC, while most older people have MLTC. And multiple long-term conditions can come with significant impacts, including loss of mobility, loneliness, social isolation, mental well-being, and pain. But despite the prevalence of MLTC, the health system tends to be organised around single conditions. And most treatments are also designed and tested for single conditions. And this can all add to the treatment burden experienced by people with MLTC. And for the reasons we've just discussed about trials, it's generally unclear if or how MLTC impacts on treatment effects. But there are reasons to suppose it might, such as people being burdened or overwhelmed by time-consuming or complex treatment regimes, drug interactions, physiological resilience, and so on. Okay, so there's been substantial work over the past decade to try and find clusters of multiple long-term conditions and explore how they predict adverse outcomes. But this work provides relatively little insight into treatment response. So as we've discussed, IPDMA can, in principle, be used to give us the power and scale to look at how people with MLTC, MLTC clusters, frailty, or other ways of characterizing multiple long-term conditions, how they respond to treatments, and therefore whether we should be making different treatment decisions. But all of this relies on there being people with MLTC in the original trials, and us being able to identify them having MLTC from the data we have available and the trial reports. So the sort of £1 million question, $1 million question, what percentage of people in drug trials have 3 or more long-term conditions? You can all take your guesses. I don't think we'll set up a poll. Okay, so the answer, if you were thinking the answer was it depends, then you had the right answer. But yeah, it's a slightly complex picture or nuanced picture. MLTC's less common in clinical trials than in community populations with the same index condition, but it's still relatively common. So some work that Peter's done, and I think you're going to talk about this a little bit in your presentation, Peter. We know that 10 to 15% of participants in asthma and psoriasis trials had 3 or more conditions, and 40 to 60% in osteoporosis and COPD trials. So I think there are still challenges with representation, but there are people with multiple long-term conditions present in the trials that we might be looking at. So we think IPDMA has huge potential to make a major head start in MLTC research by maximising the use of the existing trial data that's out there, providing answers cheaper and more quickly than by setting up new trials, without exposing more participants to the risk of trial involvement, pointing to where new trials really are needed, and enabling person-centred care by providing tailored predictions about treatment effects. So just briefly mention the team, as I said, that we're a part of, the UK Multiple Long-Term Conditions Trials Collaborative team. So you can see it's a large number of eminent people involved, 17 team members from a number of institutions, including trialists, statisticians, methodologists, clinical academics with expertise in multiple long-term conditions, and researchers with IPD datasets. And the team includes a number of members of cross-NIHR collaboration on multiple long-term conditions, and we're funded by the NIHR. Okay, so just before I hand over to Peter, I wanted to mention these upcoming seminars that we have in our series. So on the 9th of December, James Shepherd and Maria Panagiotti will be giving a couple of examples of work that they've done, looking at multiple long-term conditions with IPDMA in blood pressure self-monitoring and in collaborative care for depression. And then in the new year, on 28th of January, Richard Riley, who's really one of the world-leading experts in IPDMA methods, will be giving this introduction to IPDMA methods. So yeah, make sure that you attend those if you can. Okay, that's all I was going to say. So I'll hand over now to you, Peter. Thanks very much.
Thank you, Tom. Can I check? Can everyone hear me okay?
I can hear you fine, yep.
And that's not the start. There we go. Can you see the slides in slideshow mode?
Yes, thank
Excellent.
you.
Thank you very much. Okay, so as Tom said, I'm going to talk a little bit about some of our recent work, which has looked at this challenge of whether we can use current trials when we have access to IPD to answer questions about how we should be treating people with multiple long-term conditions, particularly because the way trials are currently conducted and reported often doesn't give us that level of detail of MLTC and whether we should tailor our approach based on those results to people with different combinations of conditions or different numbers of conditions. And we've worked with IPD in this space for some time, and what I'm going to present is some of our more recent work, which has tried to apply some of what we've learned initially on how we can quantify MLTC to a specific clinical context, which is type 2 diabetes. And I'm going to be comparing across age and comorbidity in some of the trials that we've looked at. So this is an outline of what I'm going to talk about. The first is just that broad challenge of the applicability of trials, which Tom's already kind of laid out. And then I'm going to present some of our work where we've looked at whether the efficacy of treatments differs by age. So this is not MLTC yet, although we're working up to it, as age was a slightly simpler challenge in terms of looking at this kind of whether treatments vary across individual characteristics. I'll touch briefly on our work on frailty, as that was really our stepping stone into looking at MLTC in this space. And then in the context of type 2 diabetes, really going to try and address that kind of final question that Tom raises too, really how well represented is MLTC within the kind of standard drug trials that are informing our clinical guidelines. And we've got some recent work on that, which I'm pleased to share with you, and I'd be interested to hear your reactions and questions and all these things. So randomized controlled trials, as we all know, they are the gold standard for the efficacy of medical treatments. So because they are randomized and therefore can deal with the problems of confounding, we know that the estimates of the efficacy of a treatment are causal when not prone to the problems of observational data. But while we also know that they exclude many people who have the condition that we want to treat, and so the applicability within practice can be questioned. This is some really nice work by Bruce Guthrie and his team, where they looked at the inclusion and exclusion criteria of trials across a range of conditions and showed that most people with a condition would be excluded from most trials for that condition. Now this applies to individual trials. There's a broader question about whether the evidence base, when you put the trials together, covers more or less of the population. But there is a problem that trials are restrictive. And therefore the standard kind of aggregate reporting of trials can be difficult to apply to specific patient groups such as MLTC. For type 2 diabetes, we know there's a lot of heterogeneity within the population of people that have type 2 diabetes. So there's an increasing age spectrum. We're seeing more type 2 diabetes in younger people, but also people with type 2 diabetes are often living a lot longer. And so we've got a really diverse population with quite diverse needs and quite diverse phenotypes within that. And clinical guidelines are recognizing this increasingly. So there are recommendations for individualizing our targets for blood sugar control and particularly in people who are much older or living with frailty to look for less stringent targets to reduce the risks of that. But there's still a lot of uncertainty as to how we should best tailor our treatments to individuals. Um, we also have relatively newer treatments. They're not that new anymore, but they kind of over the last 10 years, the treatment of type 2 diabetes has changed. We have more options. We have some treatments like SGLT2 inhibitors, GLP-1 agonists, which have been shown to improve cardiovascular outcomes over and above their glycemic effect. And so the applicability of these newer treatments is an important question. We know that a large proportion of people with type 2 diabetes are relatively older, and almost all people with type 2 diabetes have multiple long-term conditions in some way. Now, that includes concordant conditions like hypertension or coronary artery disease, but also things like depression or completely unrelated conditions like inflammatory disorders and so on. So there's a lot of diversity within the population that we want to treat. So the first bit of work we looked at was really whether the efficacy of these newer treatments varies depending on how old someone is. And this is something that is hard to know from aggregate data because, as Tom mentioned, trials report an average treatment effect across the population. They often report age subgroups, but the subgroups themselves are underpowered. And the standard approach, as Tom laid out, to meta-analyzing these using aggregate data is prone to ecological bias or aggregation bias. So if you just look at the age of the trial population and then you look at different trials results, you can make biased inferences about how efficacy differs by age if you don't have the IPD. So this is really where IPD comes in and allows you to make much more valid inferences about whether the efficacy of something varies by a characteristic such as age. IPD gives you greater power to do this, and it also allows you to calculate estimates, as I've said, that are tailored to individual characteristics. So this was published this year. We've conducted a network meta-analysis using IPD for some trials of these conditions, and that's the work I'm going to present first here. So this was an IPD meta-analysis based on systematic review. These are the inclusion criteria. So it was for the kind of three relatively newer treatments for type 2 diabetes, and we included any trial in which one of these treatments, so SGLT2s, GLP-1s, or DPP-4s, were compared to either a placebo or another comparator. So it could be one of the other newer treatments, or it could be another treatment for diabetes like metformin or whatever. We included trials that looked at the change in glycemia, so HbA1c as a measure of blood sugar control, or major adverse cardiovascular events. And we only included randomized control trials. We then did a multi-level IPD network meta-analysis, so I'm going to break down what our methods were. So it was multi-level in as much as we included a broad set of trials that included a range of different drugs, but these drugs exist within classes. So we defined for each of the trials what was the drug that was being compared, but also what class, such as SGLT2 or GLP-1, does that drug belong to? And our assessment of whether treatment varies by age was at the class level. So we were looking at, does the efficacy of SGLT2s as a group vary by age, assuming that that difference would be similar across the different types of SGLT2 that there were. Now that is an assumption, but that's the assumption that we made. It was an IPD meta-analysis, and particularly it was a two-stage IPD meta-analysis. So that is one of two options you have, really. It's where we took, for each trial, where we had the IPD, we estimated the treatment effect and also the age-treatment interaction. Does the effect of treatment in that trial vary by age? And we estimated that individually for each trial, and then our meta-analysis took those estimates and combined them, and did so along with the aggregate data in a way that I'll mention in a minute. And that gives you an estimate of the overall age-treatment interaction across the meta-analysis. And it was also a network, so we've got more than two treatments that we're interested in here. We're not just looking at SGLT2s and placebo, we're looking at all different combinations. And so we took that information and constructed a network where you look at all the individual treatment comparisons. This is one of our networks here where we've got various different drugs being compared to lots of different drugs. And essentially, by using a network meta-analysis approach, you can look both at the efficacy of each drug and also can look at a network level estimate for how each class varies in its efficacy according to age. And each of the comparisons inform that overall estimate, which again increases your statistical power. So to move on to our results, there were a lot of trials. So we included 601 eligible trials. We then, for all the trials that we were eligible, we tried to acquire the individual level data. And we did that through a repository called Vivly. Now, this is one of the repositories where industry sponsors share their trial data. And through that, we could gain access to 103 of the included trials where we accessed the IPD. For the remaining trials, we didn't have the IPD, but we collected data on the age and sex distribution of the trials. And working with David Philippou and Nikki Welton in Bristol, used that information to inform the network as well. So he's done some really interesting work looking at how you can combine aggregate along with IPD data to gain a more precise and unbiased estimate of interactions. Our results in a nutshell showed that for one of those classes, so for SGLT2 inhibitors, there was a lower efficacy for glycemia, so for blood sugar control, with increasing age. So the effect of SGLT2s on reducing blood sugar was less in older people compared to younger people. But the efficacy of that same drug for reducing cardiovascular events was in the opposite direction. So they seemed better at reducing cardiovascular events in older people compared to younger people. To show a bit of data to kind of show that I'm not making this up, the circled ones are the age treatment interactions for SGLT2s across 3 different networks. So SGLT2s used on their own, in dual therapy where they're along with metformin, and in triple therapy where they're in a combination. And in each of those networks, the sugar lowering effect for SGLT2s was greater in younger people. And when we looked at cardiovascular outcomes, the interaction was in the opposite direction. So SGLT2 inhibitors showed a greater reduction in cardiovascular events in older compared to younger people. When we looked then at what this means for what is the estimated efficacy across different ages, this was our estimate for SGLT2s, and this is based on IPD from 4 trials along with the aggregate data from the remaining MACE trials for this class. And you can see that there's an increased efficacy as people got older. The density plot at the bottom shows the age distribution across the whole meta-analysis, and what would be important to highlight is that above 75, the number of included people does drop off. So although this does show this age treatment interaction, we need to be careful about extrapolating this into much older ages because people over 80 were really quite unusual within these trials. And this is the equivalent plot for GLP-1 analogs in which there was some, although a weaker effect in the other direction. So they seem to look slightly better in younger people than in older. So in summary from this work, it appears that there's some greater cardiovascular benefit in older compared to younger people of one of these drug classes, SGLT2s, which are increasingly used in practice. And this is despite the fact that these treatments appear to have a less of an impact on blood sugar. Safety was comparable on the relative scale across all ages for each of these drug classes. So this, I think, is interesting. The kind of next question, though, is how like the older people we're treating are the older people in these trials that are informing these estimates. And that's where things like MLTC and frailty become important because this seems to show an age effect. But we know that there's a big spectrum of health within older people. So looking at these phenotypes within trials becomes very important, I think. So what about frailty? I will touch on this very briefly. There's more in the frailty stuff than I'm going to present today, but I want to get onto the MLTC focused bit. But we've done some work where we've tried to look at frailty within this same set of trials. The approach we've used to looking at frailty is to use the cumulative deficit frailty index. So there's lots of different models of frailty. The most commonly used one in secondary analysis of trial data is to use this cumulative deficit approach, where you look for as many criteria or as many features as you can, which get more common with age and are associated with poor health, and you can make a sum for each individual of the factors that are present, and that gives you a quantification of the degree of frailty that someone has. And this is commonly used across observational and trial data. It's the model of frailty that informs the EFI that Andy and his team have done work on. This follows a standard procedure, and you generally get an index that looks something like this. Our question was, is there enough data in the trials for us to do a frailty index like that? And what can we learn about frailty from that? This is a busy slide, but basically shows for each trial in a column the variables that we wanted to include in the frailty index which were present. And the reason I'm showing this is that the top two blocks of color, so the pink blocks at the top, and then the kind of tealy, greeny, bluey ones below them, are the long-term conditions in the trials that we thought were important for estimating frailty. So things that got more common with age and were impactful in terms of health. And they were really consistently measured across these trials, which were the ones that also included some measure of function that allowed us to do frailty. Function's the purple at the bottom. So about two-thirds of these trials didn't collect anything really on people's physical function, that kind of stuff. These ones did, but collected it fairly variably, and the questionnaires they used were different. But what was quite tantalizing in terms of the MLTC thing is that the comorbidity stuff was quite widely collected, and it included non-cardiovascular comorbidities across many of the trials that we had access to. We were able to construct a frailty index for these trials. Frailty was relatively rare in many of these trials, although in some, so trials in people with chronic kidney disease, which are the yellow distributions here, we showed much higher levels of frailty. So it does seem possible that some trials can recruit sicker populations, and there's some frailty within those populations, although the upper limit of frailty was generally lower than you'd expect to see from a population-based sample. So I think there's some frailty there, probably not the most severe end of the spectrum, but it does give us some opportunities to look at a spectrum of health states within trial IPD. And frailty in these trials was associated with your baseline risk of a number of events. So all adverse events, serious adverse events, hypoglycemic episodes, not completing the trial was associated with a higher degree of frailty at baseline, as was your baseline risk of cardiovascular events. So this, like I say, I'll move on from the frailty stuff because I want to focus on the MLTC work we've done more recently. But what this exercise in frailty showed us was a couple of things. That for those trials where we could estimate frailty, multiple long-term conditions or multiple different conditions across a range of organ systems were really consistently captured once you had the IPD. And this was way above what was reported in the published papers for these trials, where there wasn't that level of detail in the published report. Another important limitation of our frailty work is that we couldn't estimate frailty in the really influential large cardiovascular outcome trials. And that's because they didn't measure physical function. So we didn't try and do frailty in those trials. But although we concluded there was very little frailty in the trials, those trials in higher risk populations that have really influenced the clinical guidelines, we had to exclude from that frailty analysis. So there's a question as to how representative those really influential trials are. And that's what we've recently tried to do from an MLTC point of view. So the last bit, and then I'm keen to open it up for questions and discussion, is taking one of those classes as an example. So the SGLT2 inhibitors, the ones that we seem to show get a bit better with age in terms of their cardiovascular benefits, but which we might have doubts about how much frailty there may be. How representative are they in terms of multiple long-term conditions? So to do this, we used individual participant data from these trials I've been talking about. We looked at a count of comorbidities. So how many comorbidities, how many other conditions, in addition to diabetes, did people in the trials have? And also what was the rate of serious adverse events? So this is any event that results in hospitalization or death, along with a few other criteria in a trial would be classed as serious adverse event. And we wanted to know what the rate of those was, as we were keen to know whether that reflects the rate of similar events that you'd expect to see in practice. Some of our work has suggested that event rates in trials are often much lower than you'd expect in routine care, and that probably reflects the fact that trial populations are on average healthier than people that we're treating. We then wanted to compare both these things, so the amount of comorbidity in the trials and also the event rates between people in UK general practice who had just been started on treatment with one of these drugs for type 2 diabetes. So how like the people we're treating currently are the people who were in these trials. Our approach was this. So I've mentioned the Vivli repository, which is where we got the IPD before. So for each trial that we had data for, we got the IPD, we took the randomized participants, we looked at the distributions of age, sex, and comorbidity, and then we looked at the adverse event rates in the trial. In parallel to that, we accessed SAIL databank. So this is a routine care database of about 70% of the population of Wales. We looked at all new users in the last 10 years or so of SGLT2 inhibitors with type 2 diabetes. We then applied the inclusion criteria for each trial to that population, identify those who would have been eligible and would have been ineligible. And then we looked at comorbidity in those two populations. So comorbidity in those who didn't meet the criteria would have been excluded, and comorbidity in those who theoretically at least would have been eligible for the trial, and then looked at how that varies from the actual trial population and also how their event rates differ from those in the trials. So trying to look broadly at their health status. In terms of quantifying multiple long-term conditions, there's lots of ways you can do this, and I'll not go into all the various choices you could have made. What we relied on was a recent consensus piece looking at what conditions should ideally be included if you're trying to count multiple long-term conditions. And from this work, we took 57 of the 59 conditions that were recommended. We had from previous work from others a list of primary care diagnostic codes used to identify these conditions, and we manually mapped each of these to the MEDRA coding system, which is the one that's used in usually industry-sponsored drug trials to classify both adverse events and also baseline long-term conditions. So we tried to get as consistent as we could a code list between the two data sources, the routine care and the trials. The results, I'm going to show one trial first to kind of walk through what I'm showing, and then I'll show all of the trials after. So first observation was that when we applied the criteria to the routine care data, consistent with the kind of wider body of literature, most trials exclude most people with type 2 diabetes. So the blue is the people who would have been ineligible for the trials, and many of the trials, they were really quite restrictive in their criteria, although few of these criteria were specifically about MLTC. There was some of it had to do with blood sugar control, what other treatments you were on, that kind of thing. So the trials themselves are restrictive, although 89% of people in SAIL starting treatment would have been eligible for at least one of the trials. So across the evidence base, in theory at least, most people would have been eligible for something. When we looked at comorbidity, this is the distribution of long-term conditions for people eligible for this particular trial. This is one of the kind of earlier phase 3 glycemic efficacy trials for empagliflozin. So people who were eligible for the trial, relatively few had no conditions, lots had some, and there was a long tail. When we looked at those who were ineligible for the trial, so those who, again, this is people treated in routine care who would have been excluded, there was a higher degree of comorbidity. So as you might expect, the inclusion criteria for the trial excluded a lot of people, particularly those with a higher degree of comorbidity. Next, we looked, though, at people who were actually randomized to treatment within the trial, and that was their distribution. So there was a far greater proportion of people with no long-term conditions. There was a fair chunk of people with one other condition, but higher degrees of comorbidity in this kind of early phase 3 trial were relatively rare. Which, when I saw some of the responses in the chat to Tom's question about how much there is, I guess kind of confirms some instincts as the kind of skepticism we have around how much comorbidity there might be in these trials and how much do they really reflect comorbidity as we see it in practice. Not quite as low as the kind of less than 1%, but certainly underrepresentative in terms of comorbidity. When we look, though, at EMPA-REG outcomes, this is one of the big cardiovascular outcome trials we had. This is people who would have been eligible for the trial. So their eligibility criteria selected a higher risk population. You had to have established cardiovascular disease to be in this trial. And so as you'd expect, people that meet that criteria often have other stuff that comes along with that. So this trial should be recruiting a highly comorbid population, people with a lot of other conditions. People in routine care who would have been excluded were healthier. So this trial, although it's restrictive, it's selecting a higher risk group by the way it's designed. Its criteria are selecting out people with a greater degree of long-term conditions. We then looked at people in the trial, and they sat somewhere in the middle. So there was less MLTC in the trial than people in routine care who would have been eligible. Some of this might reflect underreporting. So we're looking at primary care diagnostic codes and we're looking at trial baseline stuff, and that's not an equivalent way of measuring lots of these conditions. So take this with a pinch of salt. But what it does show, though, is that there was a greater degree of comorbidity than in those who were excluded from the trial because they didn't meet those criteria. So, and there was a lot more comorbidity than in these early trials that we worry about for not having very much at all. When we dug into this, there was pretty good representation of cardiovascular comorbidities. There appeared to be less of other things like mental health problems, that kind of thing, which I think seems intuitive that, people with really complex and different multimorbidity are less likely perhaps to participate in trials or to be trials are maybe less good at facilitating their inclusion. But this was interesting and showed that not all trials are the same in terms of the extent to which they exclude MLTC. This is all the trials that we looked at, kind of ordered by their mean comorbidity count. So some at the top, which look like we worry about in terms of being very selective. Some at the bottom, the higher risk trials, where the distributions were much more overlapping than those other trials, for example. And the ones at the bottom are the ones that select higher risk populations. We then looked at serious adverse events. So this is, like I say, any hospitalization or death causing event in a trial would be classified as serious adverse event. And we looked at, basically what we did was in each eligible population, we calculated the expected number of serious adverse events, the expected number of hospitalizations and deaths based on the age and sex distribution of the trial that we would have expected from routine care. And if the trial was representative, you'd expect the number that actually occur in the trial to reflect the number of hospitalizations and deaths that occur in the community among people that would have been eligible for that trial. And if that's the case, then the dots would lie on that central line there. What we found was, for the cardiovascular outcome trials at the top, the estimates were pretty clustered around that kind of null line. So the rates of hospitalizations and deaths in the trial were pretty similar to the rates of people treated in routine care. For the other trials, though, they went from being similar to being about a quarter of the rate in the trial. So some of the trials had a considerably lower rate of events than people that would have been in the trial but were treated in routine care. So these ones at the bottom seem really quite selective. They're probably getting a much healthier population than we're treating. But actually, these big influential trials had event rates that were very similar to what we see, which may provide some reassurance as to how applicable this evidence might be. When we then standardized on multiple long-term conditions as well, the differences attenuated a bit. So simply put, differences in multiple long-term conditions probably explain some of the difference in event rates between trials and routine care, but not all of it. We looked at things like all-cause mortality and MACE and also non-cardiovascular death. The community rates, conditional on multiple long-term conditions, which is on the x-axis, is shown in red. So the more long-term conditions you had, the higher the rate of these events were. And particularly for all-cause mortality, the comorbidity-specific rate in these cardiovascular outcome trials was actually considerably higher for some of the trials than in the community. So these are not selectively healthy populations. They probably are selectively cardiovascularly unwell populations. So they're not exactly like the people in routine care, but they're certainly not selectively healthier. And then this is the serious adverse event rate, which is similar to the slide before. So in conclusion from this work, in SGLT2 inhibitor trials at least, they're not representative. They are selective, they have criteria, and they include particular populations, but some of them appear to be much more representative than others. And particularly the large cardiovascular outcome trials do seem to be somewhat more comparable to routine care, although there's obviously nuance in that. They have higher degrees of comorbidity. They have event rates that seem quite similar to what we'd expect in routine care, although the type of comorbidity is somewhat skewed towards the kind of cardiovascular stuff that you'd expect in a diabetes trial. So we need to be a wee bit careful with how much we extrapolate that. I'll stop there. Keen to hear any questions. Lots of people to thank. A huge amount of work in all aspects of this. Names on the slide, as well as our funders, and also the Vevely repository that facilitate the sharing of the data, and the sponsors who do so. All of which we couldn't do this without. And before I stop sharing, a final plug for our next two seminars. If you didn't catch the dates on Tom's slide earlier, here they are again. And yeah, it would be great to have more people at these events where we can share some of the other work in this space that's been done. Thanks.
That's great, Peter. And just to let everyone know, but everyone that's on this call today, we will email you out the links for the future seminars as well. And we'll make sure that we only have one link today for the future ones. Has anyone got any questions? Andy, are you happy to funnel questions?
Yeah, happy to coordinate questions. So yeah, just for everyone, I mean, I won't know everyone, I don't think I'm Andy Clegg, I'm an academic geriatrician based at Leeds and Bradford, and I've been fortunate to be working with Peter and Tom over well, recent years really in this area, fascinating area. And just firstly, big thanks to Tom and Peter. I mean, you've covered some hugely, I mean, fascinating but quite complex areas there, and I thought you both presented them really clearly. Actually, covered some really complicated areas and gave some really clear overviews. So thank you to you both. There haven't been any questions come through the chat. I mean, I think I mean, the kind of audience is of the size that I think we can, if people want to ask, then you can pop your hands up. But if you, just while you're thinking, I mean, probably a couple of things to kick them off from my side. So firstly, Peter, I think the last slide was really helpful, actually. And I think we could see that the trials, they're not fully representative of people with multiple long-term conditions, but I mean, do you think that they are representative enough, I suppose, is the ultimate question. Do you think it's representative enough to make reasonable inferences to reasonably inform clinical practice?
So I think it depends what your question is. I think for many patients, yes. And I think what we're trying to get at with some of the IPD work is, I guess, in what circumstances is that the case? So I think it would be a bit nihilistic and I think too simplistic to say, oh, there's not enough comorbidity there. If you've got multiple long-term conditions, this doesn't apply. Because actually, I don't think that's the case. I think that's too restrictive. And I think these trials do inform care that could apply to the majority of people that we're trying to treat in routine care. I think what it does highlight is that there are degrees of complexity and there's levels of risk with multiple long-term conditions, particularly once you've got multiple organ systems involved or complex frailty, where at least the trials we looked at, and probably trials conducted in the standard ways, are not recruiting those people. And that's the point at which we're extrapolating beyond the trial evidence, and we need to do so with caution. That would be my, maybe slightly on the fence, but I think what we're trying to do is see where the boundaries are. And for a lot of people, I think we can trust the trials fairly well.
Yeah, thanks. That's, yeah, really helpful. I mean, I've got one for, well, again, if people want to pop their hands up, that's fine. But I can ask a couple more just to get a couple of areas. So, I mean, Peter, you kind of talked about drug trials there, really. That was the focus and really interesting. But I mean, there's obviously a broad area of kind of the more health services, complex non-pharmacological interventions. And so, I mean, I know, Tom, this is kind of our area really, isn't it? And it's just whether there's any sense that without having had the opportunity yet to explore all the data, whether there's any sense that that the health services, the more complex interventions might be in any way different to the drug trials in terms of the eligibility criteria and whether they may be ultimately more representative than the drug trials, I suppose.
Yeah, I guess thinking back to our recent network meta-analysis, which was using aggregate data, so we weren't able to look at we weren't looking at the IPD, so we didn't have that kind of detailed view that Peter had. I'd say it was quite a mixed picture. So there were a lot of studies that seemed pretty representative. at least within the population that they were trying to treat. And then there were others, and they tended to be, I think, again, as Peter was suggesting, that some of the smaller trials, which were much more restrictive, much more narrowly defined. But yeah, I think it's hard to get a really clear picture without the IPD in the way that Peter's done. But
thank you, Suzanne. This is a fantastic question. We've been talking about this. This came up a lot actually at our meeting. So around AI and whether you think AI could be used to pull data from the trials to inform individual treatment decisions based on characteristics and MLTCs. Do you want to maybe take that, Peter? Or maybe both of you, maybe Peter first, and tell me if you've got anything to add. I know this was we had quite a heated discussion about this, didn't we, at our face-to-face meeting?
Yeah, this one split the room when we discussed it. So I think AI is coming and there's opportunities there. And this, I guess what I can say is what we've done here was very labor intensive and requires a lot of looking at both the data and also the documentation, the deciding what's been measured, where, and all that kind of stuff. I'm not an AI expert, and I think there's certainly those advocating for an AI role for some of that processing stuff and to streamline a bit of that. It makes me a little nervous, and some even more so, as to I think there's lots of complex decisions to be made in this work around, like, when is something absent or when's it not been recorded, and what conditions can we reasonably say are being collected, and these kind of things, which do involve quite a bit of judgment as well as just processing what's a very complex data set. And I think these considerations would need. How you square that circle, I don't know, but I think there's probably a role, but you need to be really careful, I think, how you interpret what would come out of such a thing. And there's also technical challenges that I don't have a good handle on as to how you'd actually get it to be done. I don't know if Tom has anything more to add to that.
Yeah, not much. I agree. It's clearly there's a role for AI. Particularly, actually, I think just in aggregate data, standard meta-analyses and systematic reviews. How long it's going to take for that to become reliable, particularly in some of the more complex intervention trials. I don't know. It's way beyond my understanding or expertise. But I think, as you say, there's lots of really complex decisions to be made, and for all of that to be going on within a sort of black hole that we can't explain how it came to the answer is worrying for the moment. But presumably there will be a time when it's very capable and much of this can be done.
Thanks, Peter and Tom. And Lou's got a question as well. Just come on camera, Lou. You can ask it if you like. So me and Lou haven't seen each other for about 20 years. We trained together, and it's the first time we've seen each other in about 20 years. So nice to see you.
Lovely to see you, Andy. I can just about talk. Sorry if I'm a bit lispy. And thank you so much. That was a brilliant talk, and obviously reflects a huge amount of brilliant work as well. And it was just the very first slide you showed, which was the amount of data you weren't able to get your hands on. And going to be one of those annoying people that asks about what you don't show, what you did show. If you went back and looked at that, were you able to weed out any systematic differences in those sorts of trials that you could get data on versus those you couldn't? Were the big hitters in those data that you couldn't get your hands on, and in turn how that might inform looking at this question about how reliable are the data that we do have to inform the real people we do see and try and treat?
Yeah, no, it's a really good question. The answer is nuanced. So the limitations section in our paper probably does break down that a fair bit. You're right. So we don't have a random sample of these trials, and there could be systematic differences, and that could affect findings. And I think you have to hold our hands up to that. The age interaction is probably that we'd have most confidence in because of David Philippo and Bristol's excellent work that I half understand. The aggregate data does inform that estimate as well as the IPD. For the SGLT2 inhibitors, we had 4 of the big cardiovascular outcome trials, and so we've kind of emphasized that finding. The GLP-1 finding that had a slight age interaction the other way, it relies on IPD from 1 trial out of 6 big MACE trials. And so we would de-emphasize that, as it's possible if we had IPD for the other ones that we see something different. For SGLT2 inhibitors, we've got a greater proportion of it, and we've got some methods to try and deal with that. And there don't seem to be big systematic differences. So they're similar in terms of size and their primary outcome and all that kind of stuff. But yes, we are dealing with a subset of the evidence in total, and it can influence things. So yeah, we need to be eyes open to that as well.
Thank you. Thank you.
Yeah, thanks, Peter. There's a question from Isla. Should I summarize the question? This one maybe. So it's around kind of the comparison, as we've done for trial participants versus real world characteristics, but kind of in the related areas around, say, disabilities. Oh, you're there, right, Ali? Do you want to go on? You can do a better job than me.
Happy for you to take it. Hi, thank you so much for those presentations. I don't think I know any of you. Have worked a lot more in the global health space, but I'm really interested around multimorbidity and disability. And I was wondering whether that approach that you've taken, I noticed there were a lot of gaps in the functioning data in the trials, but there's, I think, suggestion, evidence that people with disabilities might be also more likely to be excluded from trials, and whether then that impacts how relevant the outputs are for them. Is that something you'd consider looking at or have any thoughts on?
So I think it's a really important question. Totally agree with you. I think the underrepresentation of people living with disability is likely to be large because of the burden of actually participating in a trial. Short answer is we can't look at it that well. So particularly that routine care comparison, you're relying on something that's been measured in both, and also that's been measured comparably in both. We've just about managed to do it with lots of caveats for MLTC. As you said, we got some function in some trials, but it's fairly light touch functional assessment in these trials, really. What I think there is potential in the space of other things. So like, for example, in the repository Andy's speaking, I wouldn't want to speak to their work particularly, but we have really good cohort data where there's much richer functional assessment of people living in the community who we'd want to target with complex interventions. And we've got trials that are focusing on populations like that, where many of them will have done much more than the trials we're working with in terms of that functional assessment. So for these trials, no, but I think it's a really key question, and there's questions about data source and methods, but particularly in other trials where that's really the focus of what you're trying to get at, I think it's key to try and look at that. And I'll be interested to see what Andy and his team come up with. But
yeah, really helpful. I mean, for me, it kind of goes probably a bit to the kind of pharmacological, non-pharmacological intervention separation in a way, because yeah, as you said, in the pharmacological trials, one, your instinct would be less likely to be included, and also historically less likely captured data. But we know that from any trial including older people, most trials including older people will have some measure of function in there. So for example, the big network meta-analysis that me and Tom worked on, looking at community-based complex interventions. So activities of daily living was, I think, Tom, the most common outcome measure, and also collected at baseline. So you can be quite confident in the more kind of complex intervention world that depending on the group, you will have information around those sorts of things that will allow you to look at them in more detail. I mean, for me, Peter, I know we're going over time a bit, but we started a bit late, and this is really important stuff. For me, sometimes it's the other things that aren't always, well, maybe not well measured and reported in trials. So we're often interested in things around sort of socioeconomic factors and ethnic diversity within populations in trials. And it's tricky because sometimes those things are less frequently reported or not reported in a standardized way across international countries. And also, things like socioeconomic deprivation have a particular kind of context. So we have measures in the UK that we use, and they're going to be different. So it's whether there are gaps in those related areas around ethnicity and socioeconomic factors, Peter, that you've seen or not seen from the data that you've looked at. Yeah,
so when I totally agree about the importance and the challenge of that. I mean, speaking to our data, which again it's kind of pharma industry type stuff. Ethnicity is not bad, pretty consistently collected, although it's with quite an American lens. So it's the FDA classification. So you get broad groups like Asian, and then some kind of, so how useful that is depending on where your context is, could be a question, but it is there pretty much. Socioeconomic stuff in these trials, yes, very rarely recorded, and the idea of comparability across different nations and settings, I agree, is not something we can really get at with these data, unfortunately.
Mm-hmm. Thanks, Peter. And then maybe a final question. Carol's popped a question in. Do you want me to ask Carol? I can summarize. Sort of looking at value in incorporating post-marketing study data in some way as reflects the more routine clinical populations. Do you get access to that at all, Peter, through, say, the repositories that you've used, the kind of post-marketing data?
It depends what you mean by post-marketing data. Apologies if I'm just missed. So I guess there's the post-marketing surveillance stuff in terms of the observational pharmacoepi type things. There's also the kind of extended post-trial, like post-end of the trial, so that's not really what you're getting at. So
I don't think so. I think it's, I can see what the question, go on, Carol.
Yeah, sorry, that's what I meant. I was just thinking about, the purpose of those studies is to collect more data on patients with all sorts of conditions. So I didn't know if it's possible also to incorporate that individual data level.
Possible, yes. And I think a really interesting area. So we've got a few collaborations forming in terms of how we combine real world data with trial data and how we can learn from others. There's so huge potential there. There's others who would speak more expertly on it than me. I mean, one thing you can use the trial data in that context for is you're always worried with your kind of observational post-marketing data about confounding and the reliability of the estimates. Where you've got IPD from trials, you can do like benchmarking, where you try to reproduce the analysis within the randomized data, compare your result to the observational one. Where it's consistent, it gives you a bit of confidence in your observational data that it's capturing the right thing. And so there are ways of bringing these data sets together that perhaps increase the reliability of each in really interesting ways. I don't think this replaces that post-marketing surveillance thing because of all the reasons you've kind of highlighted. You want to know about that real world use and the use beyond the trial population. But I think there are ways that we could synergize them a bit better.
Yeah, that's fascinating. Thank you. Thanks.
Yeah, thanks everyone. And yeah, it probably remains for me to say huge thanks again to Peter and Tom. Really fascinating, interesting discussion as well. And thanks for the really great presentations and some really positive comments in the chat on both your presentations as well. So big thanks. And thanks to Kate for coordinating everyone. As Peter and Tom have mentioned, we've got at least 2 more webinars upcoming, and it'd be fantastic if you're interested in joining those as well. It'd be great to see you at the future ones. So I think that's all from us. Anything finally, Kate, from you?
No, just say thank you, and yeah, we'll send the recording around for this one so you can share it with your colleagues, and we'll also send everybody who attended today and signed up for this one the dates and links for the future seminars as well. So thanks very much.
Lovely. Thanks, guys.
Thank you all.
See you all soon.
Thanks. Cheers.